Hi, this is Elliot Fishman, and welcome to our first series of podcasts, basically of the new year, or maybe the second set. And what I'm going to speak to you about is abdominal pain in the ED setting, GU pathology. So we know there's lots of reasons we get CT of the abdomen. There are many reasons, from liver pathology to pancreatic pathology to bowel. There are bone changes and aortic aneurysms and dissections and on and on and on. And I'm going to come back with another series of talks on GI pathology, but this one is going to be on GU pathology. Now, one of the most common presentations in the ER beyond flank pain is hematuria. And hematuria is defined as the presence of red blood cells in the urine. When visible to the patient, it's gross hematuria. And when it's visible only on dipstick method or microscopic exam, then it's microscopic hematuria. Patients with macroscopic hematuria are the ones that we're most concerned about for having tumors. And you can see the differential of macroscopic hematuria does include a range of malignancies, but also includes stone disease, infection, trauma, endometriosis, bleeding disorders. So there's a very wide range of differential diagnosis. And of course, it's our job to be much more specific. When a patient comes to us with hematuria, the goal, of course, is us to explain why that patient has hematuria, what specifically is going on. Now, when you look at the ACR appropriateness criteria, CT of the abdomen and pelvis without and with contrast rates are 9. That's the highest rating you could get, so it's what you need to do. And you could see must include high-resolution imaging during excretory phase. The idea that you just don't do one phase, you need multiple phases, including excretory phase, is emphasized in this rating. The panel created a risk stratification system. Now, this is the AUA, so this is the urologist. For patients with microhematuria, stratified as low, intermediate, and high risk for malignancy. Risk groups were based on factors including age, sex, smoking, and other urothelial cancer risk factors, degree and persistence of microhematuria, as well as prior gross hematuria, diagnostic evaluation with cystoscopy, and upper tract imaging was recommended according to patient risk and involving shared decision-making. Statements also inform follow-up after a negative microhematuria evaluation. Now, one of the things you'll notice when it comes from the AUA, and this is in no sense surprising, the importance of doing cystoscopy. In radiology, we tend to be, hey, the CT's negative, we don't see a cause, and the bladder looks good to us, we'll stop there. Urology tends to focus a lot on getting a cystoscopy. Now, of course, bladder cancer is typically an older patient, patients over 60, 70. So if you're looking at a 30-year-old, the chance of an incidental bladder cancer as a cause for hematuria in the ER setting indeed is going to be very unusual. But again, it's important to remember that there is different ways of thinking about things. In this article by Barakas looking at microhematuria, and again the AUA-SUFU guidelines, one study found that less than 50% of patients with hematuria diagnosed in a primary care setting were subsequently referred for urologic evaluation. Performance of both cystoscopy and imaging occurs in less than 20% of patients in most series. The thing that's done in most series, probably 90 to 100% of the time, is the CT scan. And so their point about the underuse of cystoscopy and the tendency to rely on imaging for evaluation is particularly concerning, okay? So again, first of all, I think we do a good job picking up incidental bladder cancers. I'll speak about that a little bit, but I think it's a different perspective when you're the radiologist or the urologist. Now, some of the other comments they make: clinicians should perform cystoscopy and axial upper tract imaging in patients with microscopic hematuria, categorized as high risk for malignancy. If there are no contraindications to its use, clinicians should perform multi-phase CT urography. If there are contraindications to multi-phase CT urography, MR urography can be done. And if there are contraindications to CT and MR, clinicians may utilize retrograde pyelography. Now, of course, it's rare for somebody to reach category number 3. Now, when you look at the imaging of patients in the ER setting and you're looking at abdominal pain, the most common diagnoses are renal colic and intestinal obstruction. Okay? Now, we won't go through the impact of CT, which we know is significant, but again, kidney and GI are the things we're going to think about most. And from this article, which is one of the really good articles making the point that management is really well designed to take advantage of CT, whether it means admission or it means discharge of the patients. This article by Lotan, the worldwide prevalence and incidence of urolithiasis has been increasing, with the number of new cases having nearly doubled in the U.S. in the last 3 decades. Acute urolithiasis is diagnosed in about 1% of yearly ambulatory care visits and in the U.S. and European ER. So it's very, very common. And the lifetime risk for urinary calculus is 12% for men and 6% for women. There are certain risk factors: personal history, family history, urinary tract anomalies, obesity, metabolic disorders. We also know that the incidence for stone disease is highest in warm regions and during the summer months because of an increased rate of dehydration. It's kind of not to be a joke, but in the era of global warming, renal stone disease is going to be even a bigger problem. Now, when you think about stone disease, what does the clinician need to know? What do we need to tell him? Well, first of all, is there a stone present or not? Where is the stone? In the kidney, the urethra, the bladder? How many stones are there? What's the maximum diameter? And there are additional findings present. Does the patient have pyelonephritis? Does the patient have rupture of the calyces? Those become very important. Now, non-contrast scans are very important, and the AUA and the ACR agree that it's really the study of choice. If you're thinking about a stone, all you need is a stone study, assuming the stone study ends up being positive. With microscopic hematuria, and surely with macroscopic hematuria, in the presence of no stone, then you need to go further, and then you need IV contrast material. The accuracy of CT for the presence of a stone is better than 98%. So CT is really good at doing that. Now, other things that can be helpful when we speak to the referring clinician: passage of a ureteral stone will depend on size and location. Passage rate of 48% for proximal versus 75% for distal stones. And once things get beyond 7 millimeters, the likelihood is that it may not pass. And surely at 9 millimeters, that typically is the issue. Again, I try to measure the maximum diameter because stones can be oval, and that has a great impact. When you look at levels of obstruction, when you're looking for stone disease, obviously, usually you see the renal pelvis and ureter dilated, and you look for transitions. So proximal aspect, mid aspect just above the vessel bifurcations, and then distally are the 3 main levels of obstruction. This article makes the point that stones above 6.5 millimeters and attenuation value above 1100 were more likely to require interventional treatment. So again, that 7 millimeters tends to be the magic number. I don't think many of us say a stone is ever 6.5 millimeters. This article, again by Lotan: larger stone size, higher density, and proximal location are significantly associated with the selection of interventional over conservative management. Complaints of shivering, fever, leukocytosis also strongly correlate with selection for interventional treatment. That's because you're worrying about pyelonephritis or other infections. Other clinical and radiologic information may be useful as supportive findings, but they were not predictive for the purpose of choosing suitable patient management. So again, one of the things that's really good about CT is detection, definition, and really guiding management. So an example here, very nicely shown, is a stone in the proximal left ureter. At times, particularly in the pelvis, it's hard to tell if a stone is in the ureter or not. When the ureter is dilated, it's easy, but sometimes they're not dilated. Doing coronal views, as in this case, really allows you to put the stone exactly where it is in the proximal left ureter. Or in this patient, you can see differential function. There is delayed function of the right kidney compared to the left. The enhancement is not as great, and the renal pelvis and proximal ureter are dilated. And as you track it downward, you can see the stone more distally. And then we'll quickly look at different images, and you can see very nicely the stone here at about what is the S2 level. That stone, based on size and location, probably more than 60% chance it's going to pass. But again, you can see very nicely on the recons. Often the coronals will make it easier for you to see specifically where the stone is, even though there's no excretion of contrast material. And again, sometimes the sagittal view here, you see the ureter, you follow it down right to the stone. So just a very nice example. Now with stone disease, it can lead to pyelonephritis. There's no question about that. And sometimes when you have non-contrast scans only, you can say, well, the stranding around the kidney, I wonder about pyelo, correlate with urinalysis. If you gave contrast, delayed function, patchy enhancement are all things you've seen. But on non-contrast scans, if you find a stone, you can't really exclude the presence of pyelonephritis. Now, pyelo is more common in women. Usually it's E. coli infection. In most cases, initial CT imaging is not necessary. Most of the time with pyelonephritis, it's a urine diagnosis. Patient has flank pain. It's more common in diabetics, elderly or immunosuppressed patients, or patients who have a history of stone disease or congenital GU abnormalities. When we think about infection, we talk about changes in contour, attenuation, which is decreased. The decreased attenuation is often kind of like striated nephrograms. There's decreased rate of contrast excretion. There's perinephric abnormalities. All of the things that were described way back when by Bosniak. And a couple examples, nice study here where you see the left kidney. There's a full renal pelvis. There's some stranding around the kidney. Once you give IV contrast, the early phase imaging very nicely shows the patchy enhancement. This is classic pyelonephritis. At times, the question pyelonephritis versus infarction. Infarcts are typically better defined than pyelonephritis and may not have quite as much stranding around them as this case has. And you can see as we go from arterial to venous to delayed phase imaging, the patchy zones of decreased enhancement, which are seen on all phases in this case, maybe a touch better later, but they're seen in all phases. Another patient with hematuria, back pain, SC disease. Left kidney is enlarged compared to the right. The enhancement is not as great. Stranding around the kidney. You can see small nodes present, which may be just coincidental. But that patchy enhancement of the left kidney, very nicely shown. The coronal view, which compares the kidneys really nicely, shows the left kidney is larger. There's patchy enhancement. There's stranding. Again, shown very nicely on the volume rendering as well. And then as you go to later phase imaging, it shows it even nicer. Now here's a patient, hemoglobin SC disease and acute pyelonephritis. Again, that patchy enhancement nicely shown. Or in this case, with acute pyelonephritis in the patient's left kidney. I've mentioned before that at times early phase imaging can be a bit more difficult than later phase imaging. If you want to see pyelonephritis, a scan at 90 seconds is usually optimal. A scan even at 3 or 4 minutes in excretory phase is also optimal. Arterial phase at 30 seconds, you occasionally will miss acute pyelonephritis, though in most cases, as you can see here, it's fairly easy to recognize. And again, here it is on the coronal views. I will say that the coronal views, whether you're doing volume rendering or just routine coronal views, make it a little bit easier to pick up pyelonephritis because it's much easier to compare a larger segment of the kidney right to left, as well as the entire kidney, where you notice the changes in the cortical medullary interface, which is due to many different things, but pyelonephritis is one of them. And here you can see very nicely the changes shown on the excretory phase imaging. Another example, again, pyelonephritis, patchy enhancement. This case is more subtle early, But as you go to venous phase, the changes in the left kidney are better defined. You can see it here as well. So when I speak about non-contrast scans, I do make the point that non-contrast is very good for stone disease. But if you don't see a stone, things you can miss range from small tumors to pyelo to vascular pathology. And so in this patient with a renal transplant, the non-contrast scans, the kidney size was not a whole lot different than previously. But once you gave IV contrast, the patchy enhancement, the multiple areas of decreased attenuation in the cortical medullary interface, very nicely shown. And that's acute pyelonephritis. Here it is on the coronal view. So again, you need to be very careful. Again, looking at the early phase, going back again versus the later phase. The later phase images, in this case, at about 90 seconds, do better. Now, there's some things that can look like renal issues, like pyelonephritis. This was a patient who got lost hiking and was dehydrated. Patient was really a little bit out of it. They got a scan. Look at that patchy enhancement in both kidneys. And again, you might think about pyelonephritis because of decreased enhancement. And what this was actually was acute renal failure due to dehydration. Very much like those striations, long areas of decreased attenuation. We don't see dehydration all that commonly, but that's a look of dehydration and acute renal failure. So just if you see that, something to think about. Now, when we think about infection, we also then go to the spectrum. We think about renal abscess, typically focal low density lesion. Again, pyelo can lead to abscesses, thickening of Gerotis fascia, perinephric extension. At times, it's unilateral. At times, it's multiple within the kidney or both kidneys. And at times, renal abscesses can simulate cystic tumors. Here's a good example of a cystic lesion in the right kidney. Thickened wall is stranding, and this was an abscess due to E. coli, but you can imagine in an older patient with macroscopic hematuria, you might think about a cystic renal cell carcinoma. Here it is very nicely shown on the coronal view and on delayed phase imaging. So at times, it can be a little bit more difficult. Another example, look at the patient's left kidney. It's enlarged. There's some stranding. IV contrast, there's mass effect. Could this be an infiltrating tumor? I guess you have to think about it. Clinical history, patient septic. Then it makes it easier to know this is a renal abscess, which is also particularly well seen on the excretory phase imaging. So I think a lot of things we tend to think about as easy, pyelo, abscess. In most situations, with the clinical history on board, it is easy, but sometimes you just don't have a good clinical history, and particularly in older patients, it can be challenging. If you see this in a 30-year-old and the patient's febrile, it makes it easy to say it's an infection, but it's never always going to be easy. Now, there are some unusual infections. XGP is one of them, typically described as a large staghorn calculus, dilated calyces. Usually it involves the entire kidney, and you can see it here very nicely, and the patient will need a nephrectomy. With XGP, extension into the psoas muscle or paraspinal muscles is not uncommon. It's a very classic appearance. Although XGP typically, as in this case, involves the entire kidney, we have seen XGP only in portions of the kidney. And just some comments, XGP, chronic destructive granulomatous process, results from a typical incomplete immune response to a subacute bacterial infection. Only about 10% of patients with XGP are diabetic, so it's not really a diabetic type process like emphysematous pyelonephritis is. But again, pyuria and hematuria. Again, large staghorn calculus is classic. Decreased or absent renal function. The kidney is enlarged. And as I mentioned, psoas involvement. In the pre-CT era, patients would present with back pain and they would do a surgical approach posteriorly and run into a big abscess in the paraspinal muscles or psoas muscle, which was due to XGP. There's an article we wrote a long time ago. There's never been a better article on the subject, But again, pain, urinary frequency, dysuria, palpable mass are all things, plus fever, of course. Here's another example of XGP, big staghorn calculus, and this is a case where it almost looks like bilateral XGP. Look at the left kidney, also big staghorn calculus. This is the non-contrast scans, and you can see there's some preservation of the lower pole of the right kidney and more preservation of the left kidney with stranding in the renal pelvis. But you can see if the left kidney wasn't diagnosed now, fast forward 12 to 18 months, and you would see basically a lack of function and classic XGP. Here's that same patient with the cinematic rendering, particularly nicely shown. And here's a classic XGP with paraspinal involvement and the abscesses in the paraspinal muscles, very, very nicely shown right there, and shown right there as well. And here's another example, even a larger. So again, these are often debilitated patients, and you can see the presentation is not from the kidney per se, but it's this abscess involving the muscles, which is, when seen, patient has back pain, often presenting as a spinal process perhaps, or even an aortic aneurysm process. But again, very nicely shown in this example. And here it is in the coronal view. So sometimes you do have function in the kidney, but as these dilated calyces, low density, again, this patient is going to need a nephrectomy. You're not going to be able to save that little portion of kidney in the upper pole of the right kidney. Now, there are other causes of hematuria, and what I'll do is, I think, let me come back. Let me have you think about this case. In your mind, hematuria, a small left kidney that's densely calcified. What do you think it is? Think about it, and that's what we'll start up with in just a few minutes. See you then. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.